Well, I've been a physician for about 20 years now, and I have done training in internal medicine through Wayne State University in Michigan, and then I went on to do my fellowship training in pulmonary medicine, critical care medicine, and sleep medicine at Mayo Clinic in Rochester, Minnesota. And I've had the opportunity to work at Mayo Clinic for about 6 years as a staff physician. And then I've also had the opportunity to practice in a small town situation in Illinois. So before coming to Morganton, I had some idea of what a small town practice would look like. And I've been here for almost 5 years now in this area, in Morganton area. And I enjoyed practicing medicine here. My medicine practice involves a wide spectrum of conditions, including lung diseases, sleep disorders, and also taking care of the acutely ill patients who are admitted to the hospital for respiratory failure, pneumonia, or other critically ill conditions that I provide services for. Well, one of the things I noticed after I moved into this area is that unfortunately we have a disproportionately higher number of people who smoke. And that not only includes men, but also a significant number of female patients that I see in my practice that we see. And this has been a national trend, actually, where the proportion of smoking in women, unfortunately, has gone up significantly more in the last few decades than in men. So what we're seeing now is a larger number of female patients who are presenting with lung diseases like COPD, emphysema, bronchitis, and asthma. And I think one of the challenges that we face when we see these patients is to try to have them quit smoking. And we have had a reasonable amount of success. It is always a challenge to have to quit smoking. We recognize that, and we always, in our visits with the patient, we not only focus on the treatment part of it, but also on the preventative side of their lung problems, especially smoking cessation, which is really important in these situations. Well, the effects of smoking actually develop over a long period of time in most patients. In fact, if someone has smoked for 15 or 20 years, they may not have any symptoms. But at the same time, their lungs are obviously are being damaged from smoking. But because there is a lot of reserve in our lung function, we do not notice the effects of smoking. By the time they develop symptoms, most patients have been smokers for 20 to 30 years, and their lung damage has progressed to the point where they've had significant decline in the lung function. So one of the things that I always try to, when I discuss these issues with patients and their families, is try to educate them that if someone smokes, they should actually have their breathing function tested, even though they may not have symptoms. And the reason for that is that a breathing test may be able to pick up signs of disease 5 to 10 years earlier than the development of symptoms. So a breathing test, which is called a spirometry, which is a short, quick breathing test, can be done within 10 minutes, and it's available widely, not only in our office, but in a lot of the other primary care doctor's office. If that test is done on a routine basis in all smokers, we may be able to pick up lung disease much sooner than what we have been doing traditionally. Well, we use a variety of technologies in our practice, and some of these technologies have been around for several decades, and some of the technologies have been developed in the last 10 or 15 years. So I talked briefly about spirometry, which is a basic breathing test that we routinely use to evaluate the lung function in our patients. In addition to that, we use chest X-rays, CT scans, and other lung scans that are now being developed, especially for patients with lung cancer. Those tests are very helpful in not only determining the extent of the disease and the severity of the disease, but they can pick up disease far earlier than would have been possible just a few decades ago. The other type of technology or technological procedures that we are involved in is evaluating sleep disorders. This has something that has been noticed in the last 10 or 15 years, that there's a huge variety of sleep disorders in every community, just like our community too. And one of the problems that is most prevalent is called obstructive sleep apnea, which involves interruption in the breathing during sleep. And this is a condition which the patient or the person who has it is the last one to find out, actually, because they're sleeping and they're having interruption in the breathing without being aware of it. And usually they feel tired, they don't feel their sleep is as restful as it should be. Their spouses or bed partners may have noticed that they snore loudly, and they stop breathing for a short period of time. And the person who actually is going through these episodes is usually unaware of these problems, and they generally have a very poor quality of sleep. Their sleep is very interrupted because of these breathing interruptions, and they have repeated drops in the oxygen levels during the night without being aware of it. So when they wake up the next day, they feel that the sleep has not been as restful as it should have been. And some of these patients become very sleepy in the daytime, especially when it's quiet, or they may be driving, they may run into accidents. And it is not only the quality of sleep that's affected, but over time, a sleep disorder like sleep apnea can increase the risk of heart disease and stroke in these patients, and also leads to problems controlling their blood pressure. So we look at sleep not only as just about sleep quality issue alone. We look at sleep as a medical condition which affects a variety of other organ systems in their body, such as their heart and their brain as well.